I'm Dr. Fakir Abadi, and this is central nervous system infections in adults. CNS infections occur in the cranial or spinal column, and they are important because there is significant morbidity and mortality associated with these infections. Emergent administration of antimicrobials are necessary, and oftentimes neurosurgical interventions may be needed to improve outcome. CNS infections may be caused by viruses, bacteria, fungi, protozoa, and helminths. And there are also non-infectious etiologies that may mimic CNS infections, such as neoplastic diseases, intracranial tumor and cysts, medications, collagen, vascular disorders, autoimmune disease. And lastly, CNS infections may be acute, subacute, or chronic. In this topic, we will focus on acute infections. Central nervous system infections are associated with significant mortality, up to 10% mortality in high-income countries despite adequate treatment, and it can be as high as 58% in low-income countries. And in those who survive central nervous system infections, there is significant morbidity, such as focal neurologic deficits, such as hemiparesis, cranial neuropathies. There could be hearing loss or memory impairment because of significant damage to the brain as a result of the infection. Here are some reliable resources from IDSA. So the guideline that was published in 2004 for management of bacterial meningitis is still the latest guideline that is used for community-acquired meningitis. There is also a 2008 IDSA guideline for encephalitis. And in 2010, there was a guideline for cryptococcal disease, which can manifest as meningitis. So for cryptococcal meningitis, this is the guideline for it. And 2017 saw the release of healthcare-associated ventriculitis and meningitis, which we will not cover in this topic. And there are other guidelines, including COXI guidelines for coccidioides meningitis, and also guidelines for neurocysticercosis. Here's the first learning objective. Explain the pathophysiology and clinical presentation of central nervous system infections. Here's some terminology. Encephalopathy in general refers to an alteration in mental status affecting the patient's cognition or level of arousal that may be due to infection, or it could be due to non-infectious causes. Encephalitis is inflammation of brain parenchyma associated with neurologic dysfunction. Meningitis specifically is an inflammation of the meninges and subarachnoid space, which we will explain further shortly. Meningoencephalitis is a hybrid presentation of encephalitis and meningitis. There is also aseptic meningitis, which is inflammation of the meninges with CSF pleocytosis, which means increased white blood cells in the cerebrospinal fluid, but no growth of typical pyogenic bacteria on routine culture. There's also other things that we will not cover in this topic, such as ventriculitis. And these infections in general can be considered community acquired or healthcare associated. And again, in this topic, we will focus on community acquired CNS infections. Let's take a look at the anatomy of the brain. So inside the skull, you can see that essentially the brain is surrounded by several layers. Meninges refer to the 3 layers of tissue membranes that serve to protect the brain and spinal cord. So this structure is similar for the spinal cord too. So when you essentially look, so there is the skull, and then you will essentially have a dura mater or dura mater, and then there is some blood vasculature, and then there is also arachnoid mater, and then there is subarachnoid space, and that is exactly where the CSF fluid is, and then between the brain tissue and the CSF is the pia mater. So you can see that in fact, when people talk about blood-brain barrier, they're usually talking about blood CSF barrier, because In the picture in the right hand side, you can see that for bacteria that travel to the brain through the blood, essentially they have to cross this layer between the blood vessel and enter CSF fluids. And then from there, that is where you have meningitis, so that is meningeal space, and then from there they can penetrate the brain parenchyma. As I mentioned, encephalopathy is a general term that can be caused by many things, including infectious causes such as bacterial or viral meningitis or encephalitis, but also many non-infectious causes. Now, certain populations are at higher risk of developing CNS infections. That includes extremes of age, so older age, including people over the age of 50, but also infants. So in the first year or two of life, infants are at increased risk of CNS infection. Patients who are immunosuppressed, people with asplenia, either functional or anatomical asplenia, people with head trauma, and those with chronic medical and lifestyle conditions. There are two routes for CNS infections to develop. Most commonly is through the bloodstream infection. So an infection could be at another site in the body, and once it makes it to the blood, bacteremia will essentially take the organisms through the brain, because the brain is highly perfused, and then they can penetrate and enter the CSF, and then consequently enter the brain parenchyma. And occasionally there could be contiguous site infections such as paranasal sinuses or mastoid of the inner ear. So people who have extremes of these infections, the damage can actually lead to entry into the brain space. And of course, another example of contiguous site infection would be head trauma. So, people who get into car accident, or, people who have had some sort of surgery, post-surgical, if there is an opening to the skull, that essentially leaves an opening for the bacteria to enter. Now, once CNS infections occur, there are a couple of things that happen. One is that, so in this picture, we're looking at this is the blood, and on top there is CSF. So once pathogens have made it to the CFS and infection has occurred, there will be significant release of cytokines, and there will be inflammatory processes that will take place. Part of that will make the blood CSF barrier leaky, so fluids will enter and lead to brain edema, and you will see that there will be increased pressure with the CSF fluids. The second thing is that essentially either thrombosis will happen in the vasculature, or there is vasospasm that essentially reduces perfusion, and that can lead to ischemia and damage to the brain. Let's take a look at clinical manifestations of CNS infection. Most commonly, and about 70 to 80% of patients will present with either headache, and these headaches are severe headaches, neck stiffness, fever, or altered mental status. Now, there are challenges with these because the classic triad, which was a combination of neck stiffness, fever, and altered mental status, is only visible in about half of the patients, so the other half may not have the classic triad. And the classic signs of meningitis, such as Kernig sign or Brudzinski sign, have poor sensitivity, so they're not really used anymore. Whereas in older textbooks, you will see that these signs are emphasized, but they have poor sensitivity, so they cannot really rule out CNS infection. In other words, if people do not have these signs, you cannot reliably say that they do not have a CNS infection or meningitis. And symptoms alone are insufficient to differentiate meningitis, encephalitis, or brain abscesses, because there is a large overlap between different types of CNS infection, because they often present as headache, neck stiffness, fever, and altered mental status. Some patients may present with nausea and vomiting. Let's take a look at some of the diagnostic tools that are available. So blood cultures should be taken in all patients suspected of having CNS infections, ideally prior to the administration of antibiotics, but this should not delay administration of antimicrobial agents. In fact, antimicrobial agents should be administered within an hour of presentation to the hospital in patients who are suspected of having CNS infections. And then in these patients, once contraindications are ruled out, there can be a lumbar puncture performed to collect CSF, cerebrospinal fluids. And there are two things done to CSF. One is kind of like a urinalysis. You essentially analyze characteristics of the fluid. The second thing is the culture for identification of organisms, and if there is something found for susceptibility result. In recent time, there is also a CSF lactate that can be tested in CSF, and CSF lactate can accurately discriminate bacterial meningitis from aseptic meningitis unless the patient received antibiotics prior to lumbar puncture. So again, lumbar puncture is best done prior to the administration of antimicrobials, but again, lumbar puncture should not delay administration of antimicrobial agents beyond 1 hour. So on the CSF, of course, prior to culture, there is gram staining done that can be used for rapid identification of organism. And in fact, there are also molecular diagnostics that can be done on CSF. These are typically PCR, and the results should be available in a matter of a couple of hours, so that those are rapid diagnostics. And lastly, there is serum procalcitonin that can also be used to distinguish CNS infections from non-infectious causes of encephalopathy. Let's take a look at CSF characteristics. So when lumbar puncture is performed at the beginning, they can measure the opening pressure. So normally the opening pressure is somewhere between 12 to 20 centimeter of CSF. And by the way, the numbers in this table, depending on what reference you look at, you may come up with slightly different ranges of numbers. But the overall takeaway is pretty much the same. So kind of think of when things should be normal and when they are elevated or decreased. So when we say normal, we're referring to someone who does not have CNS infection or any CNS abnormality. So there is an opening pressure that's normal. The appearance should be clear. White blood cells should pretty much be absent, but no more than, it should be less than 5 cells per milliliter or cubic millimeter. And the dominance of these white blood cells should be monocytes. Protein should be less than 50 milligram per deciliter. Glucose should be somewhere between 45 to 80 milligram per deciliter, and glucose CSF to serum ratio should be 0.5 to 0.6. And the reason sometimes it's useful to look at the ratio is when someone has diabetes, for example, specifically uncontrolled diabetes, their glucose may be higher, and that may affect the way we interpret. So in those patients, it may be more accurate to compare the ratio of CSF to serum glucose, and that should be normally about 50%. With bacterial infections in the CNS, opening pressure will be increased. So as we saw through the inflammatory processes, there will be increased CSF, so pressure will be high. The appearance will be turbid. White blood cells will be significantly increased as these white blood cells are trying to attack the bacterial. And the dominance of those white blood cells will be neutrophils. And by the way, the terminology we use for increased white blood cell count in CSF is pleocytosis. So as a reminder, when white blood cells are increased in the serum, we call that leukocytosis. If white blood cells increased in the urine, we call it pyuria. And in the CSF, we call it pleocytosis. So we have specific terminology for these sites, whereas, in other body fluids such as peritoneal fluid, synovial fluid. There's not a specific term for increased white blood cell. Okay, so the dominance is neutrophils. Protein will be increased. Now glucose will be decreased. And this makes sense because bacteria need to use that glucose to grow. So as they're consuming the glucose in the CSF, that number will go down. The same with if you look at the ratio. So normally the ratio should be 50%. So now that will drop to 40% because bacteria are using it. Now when it comes to viral infections, usually the opening pressure is normal, appearance is clear, but they do increase white blood cell count. And here's what's different. For viral infections, the dominant will not be neutrophils, it will be lymphocytes. So lymphocytes have the primary role of clearing viruses. Protein will be increased. Glucose is usually normal, but it may decrease occasionally. So viruses, they're not self-replicating organisms, so they're not necessarily using glucose. And then for fungal infections such as cryptococcal meningitis, also opening pressure will be increased. The appearance may be clear or turbid. White blood cell will be increased with the dominance of lymphocyte. Proteins will be increased. Fungal species also need to use glucose to grow, so glucose will be low, and so will the CSF to serum ratio will also be low. Now let's take a look at causative pathogens in CNS infections in adults. For acute encephalitis, the large majority are unknown etiology, so typically nothing will grow on cultures, and encephalitis is mostly caused by viruses. So although most of them, we just don't know which virus because it's not easy to culture viruses. So essentially to identify viruses, you rely on, instead of a culture, we rely on, rapid diagnostics, and we may not necessarily have rapid diagnostic to identify every single possibility. So it's usually a select number of organisms that can be detected. So for the most cases, we don't know what's causing it. Number 2 is herpes simplex virus 1, about a third of cases. And then varicella zoster virus and West Nile virus. And number 1 is enteroviruses. Now let's take a look at community acquired bacterial meningitis. And for bacterial meningitis, it's based on predisposing conditions. So one condition is age. So for adults up to age 50, the two common organisms are Streptococcus pneumoniae and Neisseria meningitidis. For age 50, it's still Strep pneumo and Neisseria meningitidis, but also we add Listeria monocytogenes, and also aerobic gram-negative rods, but not Pseudomonas. So this is essentially like things like E. coli. For immunocompromised patients, it's Strep pneumo, Neisseria meningitidis, Listeria, but also Staphylococcus aureus, Salmonella, gram-negative rods, including Pseudomonas aeruginosa. So Pseudomonas only a concern in immunocompromised patients. Patients with recurrent meningitis, it's usually Strep pneumo, Neisseria, or H. flu. And patients with skull fracture, again, Strep pneumo, H. flu, or group A beta hemolytic strep. And other CNS infections that we're not necessarily will cover in this lecture, but you have seen some of them in other places, is neurosyphilis. That's essentially CNS infection. There are a couple of fungal infections that are common, so cryptococcal meningitis and coccidioides meningitis. And then, of course, TB can manifest as meningitis too, so tuberculous meningitis. Now, let's talk about Listeria. So infections caused by Listeria species are referred to as listeriosis. And the genus Listeria contains 17 species, and only 3 of them have infected humans. And Listeria monocytogenes causes nearly all cases of human listeriosis. So the other ones are not really relevant, and they are short flagellated gram-positive or sometimes gram-variable, meaning that sometimes under the microscope they may actually look like gram-negative, but in general they're considered gram-positive rods. And one thing that's interesting about Listeria is that although they grow optimally at 30 to 37 degrees, they are able to grow at temperatures as low as 4 degrees. That includes the refrigerator, so it can grow inside the refrigerator. And they can be tolerant of high salt environments. So usually when you add a lot of salt, salt acts as preservatives, but not for Listeria. So if you can think of the type of food that's on this board, essentially the cheese and some of the meat here, so deli meat in particular can be contaminated with Listeria. Now, Listeria usually enters the human host via the GI tract. Foods that are associated with listeriosis outbreak includes melons, such as cantaloupe, raw dairy, that includes raw milk and raw cheese. Other things are ready-to-eat meat, such as deli meat, sprouts, caramel apples, hot dogs, as well as pre-packaged salads occasionally get Listeria, as well as ice cream. And for most people, even if the food is contaminated, when they eat it, the acidic environment in the stomach should kill Listeria. However, if someone is taking antacids like proton pump inhibitors, that can increase the survival rate of Listeria. So in general, infection is relatively rare. Now, this dysbiosis also leads to expansion of Listeria in the intestine, because if people have healthy microbiome, the healthy microbiome can outcompete Listeria for resources. So typically, again, people who are at higher risk may have this dysbiosis. And once it gets to the intestine, Listeria, it can cross the GI border, disseminate from lymph node into the bloodstream to the spleen and liver, and across the blood-brain and placental barriers in the appropriate hosts. So essentially, once it makes it to the intestine, it will make it to other organs, and once it makes it to the blood, it can go to many places. So this is also a concern in pregnancy, because this can lead to complications of pregnancy, but also this can lead to CNS infections once it gets to the brain.